So it is 12:01, so we can get started here. So thank you everyone who's joining us, or if are watching this recording back, thank you for watching. So we have Luke Wortley here from the Indiana Rural Health Association. He is also the program director for the Upper Midwest Telehealth Resource Center. So that really concentrates too on the states of Illinois, Indiana, Michigan, and Ohio with telehealth resources. So we did send a survey out to our all over the world organizations of just different telehealth topics. And one that was a big one was reimbursement. So Luke and everyone at the Upper Midwest Telehealth Center are the experts when it comes to those telehealth resources. So obviously we'll have Q&A at the end, but feel free to reach out to Luke and his team afterwards too, or reach out and we can also provide, if we don't have the answer, we're going to refer you to Luke and his team. But Luke, I'll hand it over to you.
Thanks, Paige. Hi, everyone. I have been with the UMTRC in various capacities for some time, so you might have talked to me at some point as a program coordinator, but I took over as the program director last summer. So just to get one bit of housekeeping out of the way, we are a federally funded entity through the Health Resources and Services Administration, specifically the Office for the Advancement of Telehealth, formerly the Federal Office of Rural Health Policy. Finally, I'm also not legal counsel. So obviously we do a lot of legislative and regulatory monitoring, and we do give a lot of technical assistance for reimbursement, but just so you know, I'm not giving legal advice. So today we're going to talk about the TRC program and kind of what it does very briefly. And then I'm going to jump right into federal policy, particularly from CMS and Medicare. And then we'll transition to Michigan-specific topics regarding reimbursement, some policy, and some pending legislation in the State House up there in Lansing. And then finally, we'll leave some room for questions and answer. Even if I don't have an answer for you live in real time, I will certainly get back to you, as TA is kind of the legislative aim of the program. So that's a good way to transition to the fact that the Upper Midwest Telehealth Resource Center is the telehealth resource center that Paige mentioned that covers those 4 states. Our parent organization is the Indiana Rural Health Association, which is a 501c3 not-for-profit based here in Indiana. We are all over the state in terms of staff. For instance, I'm in Indianapolis. Many of us are in Terre Haute and everywhere in between, and even some folks up north. So that's kind of the programmatic structure here. But what we are also a member of is the National Consortium of Telehealth Resource Centers. The National Consortium is, I believe, 6 years old now as of the end of this grant year. Each of the regional telehealth resource centers has had this particular funding mechanism from HRSA for nearly 12 years at this point. But the National Consortium basically does what we do, which is, being a telehealth clearinghouse. But they cover all 50 states. We just cover these 4. The other 11 regional resource centers cover the rest of the U.S. states as well as the U.S. territories, including Puerto Rico and the Virgin Islands. We also have 2 national centers that are members of the consortium, which are the Center for Connected Health Policy, which I'll be referencing quite a bit in this presentation, as well as the Technology Assessment Resource Center based up in Anchorage, Alaska. So that's the map of all of the different regions and what your regional telehealth resource center is. Obviously, if you need questions answered outside of the UMTRC region, I'm happy to direct you to those PIs or PDs. So as I said, the TRCs are kind of a telehealth clearinghouse, really. I mean, we do technology assessment, policy and regulatory monitoring, as I said, answering individual technical assistance. We also provide individualized education, training, webinars, like we're doing here today. We also have a variety of media that we put out, including a podcast. So without further ado, I'm going to go ahead and jump in. So from the federal perspective, I think many of us on this call are going to be obviously familiar with the fact that things changed pretty dramatically in terms of telehealth reimbursement. And even just the provision of services after the declaration of the public health emergency and the onset of the COVID-19 pandemic. So I'll go over this relatively quickly. just to cite the Consolidated Appropriations Act of 2023 and the calendar year 2024 physician fee schedule that went into effect January 1st of this year, enshrined, at least until the end of 2024, most, if not all, in many situations, of the telehealth allowances, not only for provision of services, but also for reimbursement. And don't ask me to pull out a crystal ball because this is a federal election year. So movement on telehealth legislation, as far as this is concerned, has been relatively slow going and not necessarily top of mind on the Hill. So to give you a little bit of a quick breakdown of some of those Medicare flexibilities that were enabled throughout through the rest of the calendar year. CMS will pay for Medicare Part B services that use telehealth as a substitute for in-person visits with a two-way interactive technology. It is important to note, and I will reiterate this a couple other times, that CMS on the federal level will not reimburse for asynchronous telehealth programs, with two exceptions. Normally, this would come with a lot of restrictions, but as I said, with the onset of the public health emergency, a lot of waivers went into effect that removed certain geographic and originating at distant site requirements, dramatically expanded the credential base in terms of licensed professionals that could bill for telehealth on the federal level to Medicare. And of course, originating in distant sites, including rural health clinics and federally qualified health centers. And many services now at the federal level are still reimbursable via audio-only codes. I will make a reference to that pretty soon if you need to reference that particular list of services. And one of the big ones in terms of providers was being able to temporarily have the suspension of establishing patient-provider relationships in person before switching to telehealth modality as a care delivery mechanism. So as far as eligible services and specialties go, beyond the high-level thing that I just mentioned, is that throughout the rest of this year, any eligible practitioner who could normally bill Medicare can bill for telehealth, essentially. This includes physical therapists, occupational therapists, speech language pathologists, and other licenses that we wouldn't have been able to bill for pre-pandemic. And as I said, this link right here, I will send these slides out after the presentation. This link right here in orange is a list to CMS's either downloadable PDF or Excel file that gives you a list of the current eligible services that you can bill for under the Consolidated Appropriations Act and the physician fee schedule, that not only outlines the relevant code, but also whether or not it's eligible for audio-only reimbursement on the federal level, and a brief description. As I said before, CMS on the federal level does not reimburse for store and forward asynchronous telemedicine, with the notable exception of federal demonstration or proof of concept projects in Alaska and Hawaii. That is a little bit different, of course, in Michigan, and we will get there momentarily. One more big thing on the federal level that I wanted to touch on was at the end of fall here. The Drug Enforcement Agency and SAMHSA and a bunch of other federal agencies and committees and Congress people got together and extended their temporary waivers. So every bit of flexibility that the DEA waiver program had put in place during the public health emergency, temporarily extended those to the end of November of 2024. And then they put out that rule for comment and received over 38,000 public comments across the country. And so they went ahead and, in accordance with other health and human services legislation and other bills that were sponsored in a similar vein, went ahead and extended those flexibilities through the end of this calendar year. An executive summary from the website itself and the full text can be found at the Office of the Federal Register, right there at that link. Essentially, it continues to allow the provision for prescribing controlled substances via telehealth, even without the in-person patient-provider establishment requirement through the end of this year. And it allows for the prescription of medication for opioid use disorder, including buprenorphine, via telehealth. So that's a big win. And I think the American Medical Association, as well as many other agencies, are in full support of this. Then again, also don't ask me what the future of this holds. I'm not entirely sure. So I'll get into just a little bit on the federal level, because I think most people who bill Medicare have a procedure in place. So I can absolutely answer questions in real time or make clarification later on if you have a particular Medicare or CMS billing or coding question or reimbursement question. But I just wanted to put it again at the top of mind that this is a general election year. The attention of Congress, as well as the voting public and advocacy groups, is not necessarily laser focused on, digital medicine advocacy. Though I will say that health equity continues to be at the forefront of the Biden administration's strategic plans, including for rural and underserved populations, regardless of geography. So that is something to keep in mind, especially as infrastructure funds from the BEAD program continue to proliferate throughout the rest of this year and in the years to come for broadband expansion and infrastructure building, which is going to be a huge component, obviously, of our work at the telehealth resource centers. There have been quite a few bills introduced. Some are in various stages of being read at the committee level, out of the committee level, maybe going to a vote on the floor, but who knows how long those are going to get pushed back or if they're going to get reconfigured. But one example will be the Rural Telehealth Expansion Act that tries to amend existing rules and regulations at the federal level about trying to be as inclusive about telehealth coverage and reimbursement as possible. Some other enterprising Congress people are introducing a federal payer parity law, which I'm not sure where that will go, but that is something to keep your finger on the pulse of. Reproductive health, including teleobstetrics and other services, continues to be the center of the national debate over many policies, and that certainly trickles down to the telehealth resource centers to field those questions as well. If you want more comprehensive coverage to find out what stage of these pieces of legislation are in the process, you can find that on the Center for Connected Health Policy website, who I referenced earlier as one of our national centers in the national consortium. So before I get into the state level, which will take me a little bit longer because I'll be a little bit more granular, I wanted to pause and see if there were any questions. I see somebody raised their hand.
Yes, I might have to.
I was gonna say we can use the Q&A or chat function, or you can unmute. I don't really have a preference.
Yeah, and now it's down, so I'm not sure who raised it.
I believe I didn't see either.
If whoever wants or had their hand raised, feel free to do it, or if you want to utilize the Q&A or chat, we can read it off there too. But I know I have to, allow the attendees to talk when it's webinar. So give it a minute here, see if they raise their hand again. Or
the chat function is also totally acceptable. I don't mind pausing or even circling back to maybe add further clarification later on. Oop. Okay, so let's get into the state level then. Let's talk about Michigan specifically. So in terms of like pure language in the Michigan Administrative Code, a lot of Michigan Medicaid, who's going to be the center of this particular overview right now, mirrors CMS's language in terms of what telehealth is and what it is not, how you try to adhere to the highest standards of care, and that it's, that it must be deemed clinically appropriate, all these things, right? That's mainly for provider stuff. But what we're here to talk about is what they pay for, when, and how, and that sort of thing. So at a glance, and this is a little bit different than the CMS regulations, Michigan Medicaid will reimburse for, depending on certain situations, there's some nuance. Many live audiovisual connections, right, which is what I think we traditionally think of when we think of telemedicine application. Michigan Medicaid will reimburse for certain store and forward situations, and I can provide you a list of some of those codes later on. We'll get into some of that here in a minute. There is some wiggle room for interprofessional consultation, remote patient monitoring, and many audio-only codes as well, which I will specifically highlight in a later slide. There is a coverage parity law on the books in the administrative code, but payment parity is not mandated in Michigan. In fact, in our region, the only state that does have a payer parity law on the books when it comes to telemedicine reimbursement is Illinois. So Michigan, Indiana, and Ohio do not. And quite frankly, that is the norm across many states throughout the US, especially east of the Mississippi River. So if you want a more detailed payer matrix that kind of gives you an idea of those kind of top 5 categories that I've listed there, and like which private payers pay for what, and which and what Medicaid covers in comparison to one another, you can find that on this link as well as on the Upper Midwest Telehealth Resource Center website. I'll be referencing that document several more times throughout the course of this presentation. So when it comes to the state, in terms of definitions and allowances, the Michigan Department of Health and Human Services has a lot of similar language to the federal level, but essentially, if you go into the administrative code, it outlines what is deemed clinically appropriate to use telemedicine for as a substitute for in-person care. And I think, we just trust providers to make that determination in the best interest of the patient from a regulatory and legal standpoint. That's why this is in there. But the relevant piece to this conversation is that, of course, documentation is extremely important. We're talking about informed consent, following the requisite HIPAA compliance, and of course making clinically appropriate decisions in a digital interface. And so just to elaborate a little further, the patient location is determined appropriate by the provider, and so that will be obviously determining your place of service modifier, and that's important to document. And Michigan Medicaid allows all Medicaid enrolled practitioners in the state of Michigan to bill for certain telemedicine codes, provided they meet those eligibility requirements. And I also highly recommend, if you have not looked at the Michigan Medicaid Provider Manual, to do so, even though it is mainly geared toward providers and like practice focused. There is a lot of really good like administrative reimbursement information and definitions and terms, and just a good way to like lay out a workflow in accordance. So I highly recommend that document published by the state. So I'll go into it here a little bit. Some common codes and a few clarifications. E-visits, audio only, and telephone codes and virtual check-ins are reimbursed under Michigan Medicaid. E-visits follow the code 99421 through 23. Audio only and telephone codes 99441 through 43, and then 98955 through 68. And then, of course, the G codes for virtual check-ins. Those are all reimbursed, and those are that list is exhaustive. That is exactly what Michigan Medicaid reimburses for e-visits, audio only, or telephone and virtual check-ins. In terms of remote patient monitoring, that is very dependent on the situation, and quite frankly, I'm not entirely sure that if you gave me the curveball right here and now, that I would be able to readily come up with that that number combination on the spot. So if you do have a specific question, please just kind of like file it away, either put it in the chat or ask it at the end, and I'll be sure to get you a definitive answer later on. In terms of modifiers and place of service codes, Michigan Medicaid demands that place of service codes be reported as if the service had taken place in person. So for instance, the old modifier 02, that the patient is not in the home, or the patient is in the home, or et cetera, as the originating site. Modifiers for Michigan Medicaid do include both 9.3 and 9.5, 9.3 being the additional modifier added for services that took place after the declaration of the public health emergency. I expect some of this to stay put, some of this to maybe be modified ever so slightly, but I can't tell you what's going to happen up there in Lansing either. So for Q3014 reimbursement for authorized originating sites, and I will give you the list of those distant site, originating sites here. So those are local health departments, county mental health clinics, or publicly funded mental health facilities, a federally qualified health center, a hospital, a physician's office or other practitioner's office, hospital-based renal dialysis centers, rural health clinics, skilled nursing facilities, tribal health centers, and local health departments. So it's a pretty extensive list, and if your originating sites are those locations and you're not trying to get the qualifying originating site fee, you might have a few extra dollars coming your way, just something to keep in mind. I was like, I misplaced one of my slides. So I will talk about first, just because it is chronologically on the presentation here, is what's going on in the State House right now. There are two House bills that have made it to the second chamber. So they have passed committee, passed the House, passed another reading, and then are now out of committee and not on the floor for a vote yet, but they are potentially pretty significant. House Bill 4131 proposes an amendment to the existing private payer laws in Michigan that really do pave the way for that payer parity piece that I was talking about with Illinois. So that will be interesting to monitor, because then that really dramatically affects how Cigna or Aetna or insert private payer here, what codes they reimburse for and how much. House Bill 4213, which is in a similar position, essentially enshrines telehealth coverage almost universally for many parts of the Michigan Medicaid program, and also tries to make semi-permanent those audio-only coverages for federally qualified health centers and rural health clinics. So both potentially significant pieces of legislation. We'll see how they do in the Senate. In terms of clarifying language surrounding telehealth language and payment parity, there are a lot of proposed amendments that are in various stages of reading very early in the process. So I didn't really feel the need to actually cite the specific bills that have been introduced. But just so you know, there's a lot of, I think, unification, streamlining, that sort of thing seems to be the priority of telemedicine advocates up in Lansing. Again, more extensive coverage can be found at the Center for Connected Health Policy website, as well as on the Michigan Legislature website itself, where you can search your key terms and see what's potentially coming down the pike. So I want to draw your attention to this table here. These are the list of codes for live audiovisual and audio only codes that Michigan Medicaid reimburses for. Obviously, I'm going to send this slide deck out, so feel free to use this to your advantage. It is also included in the document that is up on the Upper Midwest Telehealth Resource Center website under the Resources tab, and you can just scroll to Michigan and find this reimbursement guide, which was just updated at the end of November 2023. So as of right now, it's pretty up to date, as there has not been any kind of seismic shift in the way that that Michigan Medicaid is reimbursing for telemedicine. So I want to draw your attention down here to the bottom. I was talking about the use of the 9.3 or 9.5 modifiers. Those 7 codes right there do not require the 9.3 modifier. So just something to keep in mind. But the rest of these codes are things that Michigan Medicaid reimbursed for. I will draw your attention back to this slide here, which contains the link to the Michigan Medicaid not Medicaid, but just the Michigan reimbursement guide. As it does in fact have a payer matrix that includes all of the big name private payers in Michigan and kind of an overview of what they will pay for, and then an extensive breakdown of which modifiers they require and which allowable codes for, we talked about e-visits, audio only or telephone, virtual check-ins, RPM, and what is actually specifically not reimbursable. It just didn't seem like a good use of our time to go over Aetna, BCBS, Cigna, United Healthcare, like all of the various ones who have similar reimbursement structures with some nuanced differences. So all of that is located on our website at this link right here. So I'm going to pause there before I get into how to contact us, and I want to really leave some time to have 10 to 15 minutes or maybe even longer, because I know we budgeted a full 60 to get into the nitty gritty, because I think a lot of people know the overview of the reimbursement, but they might have some more specific questions, maybe beyond even this table. So I'd like to open it up for just a few minutes so we can get our conversation going and keep my brain churning in the right direction here.
So yeah, feel free to raise your hand. I can unmute you or put it in the Q&A or chat. And if any questions.
I guess for what it's worth, I don't have a visual representation, but if people are interested in a high-level overview of private payer in terms of what is allowable and what is not, we can get into some of that. I just think that going to that link is pretty exhaustive in terms of what's there. Okay. Well, Paige, I will go ahead and move on, and maybe we can circle back here in a few.
Yeah. So.
All right. Let me, just because, there we go. Okay, so I provided a few extra resources that have been linked throughout the presentation, but like just to have it all consolidated into one space. I used our website for our Michigan specific resources. I do see a Q&A here. Can we use these codes for medical decision making or only by time? That is a really good question. I am assuming, okay, hold on 1 second. I have a note about these particular codes here. There we go. There they are. So I will get you a more definitive answer on this in just a minute. So let's see here. So Jody, do you mind? I'm gonna put my email address in the chat, but this I believe is by time. I do want to be absolutely certain on that. So I want to make sure that I get back to you. That's my direct email address. You can also email just the organization that will forward to me anyway for technical assistance questions. But I believe that this is, in fact, by time, but I want to be 100% certain because our other states do it a little bit differently. So I want to make sure that I'm thinking about it in the right context. All right. I'm not seeing another chat here yet. So I will go on to the Center for Connected Health Policy, which is an incredibly useful website that does an annual publication of all 50 states reimbursement guides and breakdowns of current legislation, definitions, terms of use, et cetera, et cetera, et cetera. And that's a massive undertaking from our folks out in California. And I highly suggest checking that out, especially if you want to use their web tool that allows you to actually compare state by state to see kind of how you maybe stack up to similar regional states that may not fall into the UMTRC but might be demographically similar to Michigan. So that's something that I think is worth looking at. I will reiterate, the Michigan Medicaid Provider Manual is a tremendous resource. Their telemedicine chapter is really comprehensive and offers a lot of good guidance. And then finally, I think this is a relatively this might be relatively unknown to some people, but the federal government, in terms of HHS, has actually developed telehealth.hhs.gov in recent years, as another kind of clearinghouse option that aggregates a lot of not only data and guidelines, but also uses TRC, or Telehealth Resource Center, resources as well, and promotes a lot of good federal level educational opportunities, trainings, webinars, that sort of thing. I think it's worth checking out that website and poking around a little bit. So that's something to keep in mind. And then I only wanted to present for about 30 minutes because I know I'm in a room with a lot of people who are pretty familiar with the overview of billing, coding, reimbursement, how it goes, what is the, you run the numbers, right? But I wanted to leave some room for maybe to get into the weeds of some of the very technical questions, if we have some, or even some of the bigger, kind of more wishy-washy stuff. You know what, Paige? If you don't mind, I'm going to stop my screen share for a moment, and I'm going to pull up. Okay, here we go. Send out an email. Yeah, of course, Scott. I will provide. I've already provided Paige with a copy of the slides with all of the links embedded in those, and I'm sure that those will be delivered to registrants at the conclusion. But Paige, if you don't mind, I'm gonna pull up that payer matrix from our website real quick.
Oh yeah, go ahead.
So that we can actually just look at the specifics. It was a little bit too big of a screen grab for me to fit all on one slide, so I just let it slide for now.
Yeah.
Here we go. Here we go. We'll go back to sharing my screen. Okay, perfect. So just to put a finer point on it, this is the reimbursement guide that you can find at the Upper Midwest Telehealth Resource Center website. And you just go to this resources tab, and you can just drop right down to the Michigan resources and find this reimbursement guide, and it'll take you to this PDF, which is very comprehensive, done in conjunction with our partners out of Illinois, called Rural Med. And this will also be updated here in the next couple months. I think at the end of May will be our next update, just to make sure that we're all providing the exact up-to-date information. So for what it's worth, you can use this payer matrix to sort of find exactly which eligible codes. And you'll notice that some of them have just telehealth eligible code written out next to it. And that's because it's like a big table, like the one that I showed in the presentation earlier. So it's these other lists are not necessarily exhaustive, but they will be if you go to that particular payer's guideline. So for instance, we'll start in alphabetical order with Aetna, and you can see all of the different, what is reimbursable, what is allowable, and then again, the list of codes, what is allowable via an audio only connection, which does not require a modifier, and then of course, which modifiers, if a modifier is required, they prefer to use. So for instance, Aetna uses the GT still, that sort of thing. You'll notice that Cigna does not reimburse at all for e-visits. And then some of the other big providers are much more permissive, while others are a little bit stricter. This is a if the parity law includes Medicaid managed care organizations. Scott, I think that they do, but because I would assume that it works similarly to the way that it does in Indiana, Illinois, and Ohio. But I'm going to make a note of that. So Jody, I'm going to get back to you on those G codes, and then Scott for managed care organizations. But I just want to make sure that I'm absolutely definitive. And I already put my email in the chat, and I will get back to you as soon as we get off the line here. So I did again want to just draw your attention to this document because that at a glance thing is really nice. But we do have a specific breakdown as well of each individual private payer as well as Michigan Medicaid. And then we have federal resources on our website as well as telehealth.hhs.gov should you have any questions for fee-for-service Medicare billing or anything like that. I am going to temporarily stop sharing again just to kind of bring it back to maybe a more conversational tone to see if anybody has any extra follow-up here. And Paige, if you don't mind, could you make sure that I get Jody and Scott's contact information too, just so that we have it two-way?
Yes, yeah, I will email you their emails this afternoon.
Perfect. So I'm curious if anybody has anything else to get really nitty-gritty, or if we want to leave it at the high level here and then maybe follow up with me later if you find yourself in a thorny situation. I will say I think one of the things I did not talk about that is a hot topic of pending legislation is the idea of joining compacts and interstate licensure. This is kind of a perennial topic of discussion in the digital health realm, and how that affects who pays for what and how it gets paid for and who bills for it. Unfortunately, that territory is still relatively murky if you do not participate in a compact, but are allowed certain dispensation under the telehealth waivers. So just something to keep in mind.
Any other questions for Luke? Feel free to raise your hand or again, chat or Q&A. But as you said, yeah, if you have any more nitty-gritty questions, of course, feel free to email and I will provide your contact information, Luke, to everyone too with the slides. And yeah, once we get this up, the recording up, hopefully later today.
Yeah, of course. I saw there was a question here. Hold on, my Zoom minimized there. Okay, so a virtual check-in. Yeah, so a virtual check-in is I think it was originally a Medicare program, part of Part B, that basically covers any kind of like brief technology-based communication with a provider. These are very short increments of time. They're not really necessarily reimbursed at a super high rate, but they are vital resources for Medicare beneficiaries, as well as other folks on other insurances, just to be able to briefly communicate with a doctor without necessarily a set purpose, if that makes sense. And so it just basically means that the virtual check-in can't relate to a medical visit that you've had in the past week, and it does not lead directly to a referral. It is a very kind of like specific niche thing that you can get a little bit of money for if you have patients who want to do just a brief, hey, I got a couple questions. Can we chat through X platform, or even what, something like that. That's my best explanation for what a virtual check-in is, I think. Um, the difference between an e-visit versus a virtual check-in, huh? Yet another nuanced topic here. But it's an interest. I guess I should say it differs ever so slightly, because an e-visit is like specifically designed to try to lead to a diagnosis, whereas a virtual check-in specifically is not supposed to be for that purpose or for any kind of like referral. But yeah, it's pretty gray because, of course, those things overlap quite a bit. If you start out as a virtual check-in, but then it turns into an e-visit, yeah, but that's the dividing line, right? Is that the e-visit is specifically designed to lead to a diagnosis, whereas the virtual check-in is a brief encounter for the patient to have access to the practitioner, without it necessarily relating to a specific condition. I hope that's as clear as mud. Virtual check-ins are, I believe, billed in 15-minute increments. I can get you something definitive here in just a second. I wanted to make sure. Let's see. Yes. And let's see, Gabrielle, I will also follow up with you to get you the like sort of definitive language. But yes. Got it. Okay. So rural health clinic reimbursement list updated in January. Okay. So then maybe that particular clause is out of date. I will ask our partners if this document maybe needs to be revised, but let me look back here. Oh yeah, I see what you're talking about now. I see that amendment. You're right. So we need to update that. We just not gotten a whole lot of questions about those particular codes at any point in time here because it's been so routine. I think one of the interesting things about having to have living for the past 4 years under these expanded rules has been that much of this has become more integrated into routine, and so we're not getting as many TA questions to correspond to those particular things. But thank you for pointing that out. I definitely need to contact our folks at Rural Med and make sure that that's up to date and revise that document accordingly. And Gabrielle, I will circle back with you on that topic as well. So Jody, Scott, and Gabrielle so far.
Any more questions for Luke before we sign off? Don't see any in the chat.
And I do believe in the chat, I've given both my personal email as well as the organizational email, which just forwards to me anyway. So if you do have follow-ups or need a point of clarification, please feel free to reach out to me there. And I will go ahead and say check out our website as well. Gina says, didn't see the email. Yep, Scott, I will I will email you and Gabrielle separately about those rural health clinic stipulations.
Let me see.
I put it in the general chat for what it's worth. Oh, it's just hosts and panelists. That's what
Oh,
it is.
let me see
Let's
if
go
I
to
can.
everyone.
Yeah, let me.
I got it.
Everyone. Okay. Gonna say there, that might. And I'll send it with the PowerPoint
And
again too.
yeah, and our contact information is all listed on the slide deck as well. The other thing that I want to point you to is to check out our podcast called A Virtual View. Lots of great interviews about a lot of great topics. And if you're interested in being a guest on it, please let us know. I think we're kind of always hungry to talk to folks who are in clinical or billing or administrative workflows. And if you have any interest in that, please feel free to contact me or Danielle Rankley. So I believe that should have gotten everybody. And Joy. Yeah, I'll get you all some clarification on that, on those three codes for RHCs.
Yeah, that sounds great. Well, thank you so much, Luke, and thank you everyone who's in attendance today. And like I said, I will hopefully get this uploaded, this recording, and we'll send over the presentation that Luke had. But yes, please feel free to reach out to Luke with any more of those detailed questions. But thank you so much, Luke, for presenting today. And hopefully, yeah, have more questions to kind of, is the reimbursement list sent out with the slideshow? Will that be?
Yeah, so
Okay.
yeah, our reimbursement guide with Medicaid's updated list of codes will be sent out in link form, and you can download the PDF from our website directly too.
Sounds great. Well, if there are no more questions for today, I'll give you a few minutes back, but thank you, Luke, and thank you everyone for attending today. You all have rest of a really nice day, as it is right here in the thumb, but I'm not sure how everyone else is, but have a nice day overall, and thank you again, Luke.
Thanks, Paige.
Yes. Bye.